Now we have a most exciting session coming up because there have been so many advances on lipid lowering agents with the onset of inclisiran and all these medications. This is sponsored by Novartis. And for chairing the session, I call upon our distinguished faculty, Dr. Rajiv Bhagwat sir and Dr. Bhupen Desai sir. So please take charge of the proceedings. Thanks.
Good afternoon. So let's have this first speaker without much fuss. Bhavesh, all yours.
First of all, a big thanks to Dr. Pelajani sir, Satyavan Sarma sir, Gupta ji and Milind for this invitation. Beautiful discussions we've had, and I've been told to quickly finish the talks so that the discussion is long. But it's a very long topic and I'll try to do as much justice as I can. So I will start with this very thought-provoking statement, and it says that atherosclerosis is potentially the most preventable or treatable chronic disease. I don't know how many of you will agree, but this is how it is. But yet, though it can be prevented, it can be treated, it is the greatest cause of disability and death in the world today. And why I say that? Because we are all born with an artery which you look towards the left side, a pristine, clear coronary artery without any cholesterol deposit, and we let the years go by and we let the lipids, the LDLs all accumulate in the arteries and give rise to a coronary artery disease with either stable or acute coronary syndromes. We all know that cholesterol is essential. It is very much necessary for the functioning of the cell membrane, and it's an essential part of so many important things like steroids, hormones, vitamin D, so on and so forth. But what we many times forget is though cholesterol is essential, LDL cholesterol is not essential. We know that even if the LDL cholesterol is very, very low, there is no impairment of cellular cholesterol production. Let me see the control L. Okay, sorry. And we know that every cell in the body and even the brain can produce its own cholesterol and not depend on the liver to send them the cholesterol through the LDL cholesterol. So the role of LDL cholesterol is really not very essential. So what is the normal LDL cholesterol? And in this very nice study, we saw that in the neonates, the LDL cholesterol normal level at birth was 20 milligram percent, 20 plus or minus 10. So with such low LDL cholesterol, they still have an extraordinary development. We all know that neonates and children, they grow so fast, they need all their metabolism. And with this low LDLC, they still grow fast. And hence, we can be sure that low LDL levels are not a problem for growth or for any metabolic activity. We all have probably seen this slide. I want to just bring it to your notice that as you see on the x-axis, we have the events from coronary artery disease, and on the right side, on the y-axis, we have, or rather the other way around, the LDL cholesterol. And when we see that with every rising LDL cholesterol level, there is an increase in the event rate. And if you extrapolate it backwards, then we almost come to believe that if our LDL is lower than 55, then perhaps there won't be any event. Of course, this is really a little bit far-fetched, but we all know about this nice study by Scott Grundy, and which says that if you take LDL cholesterol as a normal value as 40, then for every 30 milligram percent increase of LDL cholesterol, there will be an increase in cardiovascular event rate by 30%. So there is a linear relationship between the LDL cholesterol levels and the event rate from coronary artery disease. Fortunately for us, we know that lipids can lower LDL cholesterol, and not only they can lower the LDL cholesterol, but they can also reduce the major cardiovascular events, both for secondary prevention and primary prevention. And look at these numbers. If you were to reduce the LDL cholesterol by 40 milligram percent, you have a 20% relative risk reduction in both secondary and primary prevention. And if you have a very high cholesterol level, then if you reduce the LDL by 160, then you could have a 80% reduction of both primary and secondary events. Then we have this very nice trial, the CTT meta-analysis, more than 170,000 patients of 26 randomized trials. And they again told us the same thing, that if you use statins, if you reduce their LDL cholesterol, then you have a reduction of all-cause mortality, coronary deaths, coronary revascularization, and fatal and non-fatal strokes. What happens when we give high-intensive statins? Why does the patient improve? So here we have on the left a patient with a high lipid core plaque in the coronary artery, a cross-section of the coronary artery. And you can see that if you give them intensive statin treatment for a period of time, then here on the right side you see that the lipid core has significantly reduced. And there is an increase in the fibrotic plaque around it and also some increase in the calcification. So what essentially this intensive statin therapy is doing is changing your plaque, which is prone to acute coronary syndrome, prone to plaque ruptures, and making it a stable plaque, thereby improving the mortality and morbidity of these patients. The same thing can be beautifully seen in this slide here. This is a patient who has been angioed with a tight LAD stenosis here, and this is a angio done again after 1 month of intensive lipid lowering therapy. And you can see here, this is the NIRS image. This is an infrared spectroscopy, which is an extension of IVUS imaging, and now available at Lilavati and most of the high-end hospitals in the city and the country. And you can see the yellow are the lipid plaques, and you can see that initially there was a lot of lipid content in this plaque, and after intensive statin therapy, it has done a significant reduction in the lipid, and thereby the plaque, which was probably a very unstable plaque, has become a stable plaque. We have learned that lower the better for LDL cholesterol. But what is the lowest that we can go to? So here is an interesting paper which says that even up to 25 milligram per deciliter of LDL cholesterol could be enough to nourish the body cells. And then you have a comment by Eugene Braunwald himself, who says that LDL cholesterol of even less than 0.5, that is 20 or less, and even ultra low levels of less than 0.3, so around 12 milligram percent of LDL cholesterol is well tolerated and safe. So that is how low we can go. Fortunately, we have all our statins, the high intensity statins, rosuvastatin and atorvastatin, which reduce our cholesterol levels by almost 50 to 60% when used in the right dosages. And that too without giving serious side effects. We know that statin therapy is much safer than low dose aspirin therapy. The risk for rhabdomyolysis and liver failure, which are really the worrisome side effects, is extremely rare. And of course, we do see some increase in the glucose levels, but the offset, the disadvantage of this slight increase in the glucose is offset by by a significant improvement in the mortality, morbidity because of the reduction of the LDL. So overall, statins very effective and very safe. So we have seen how low we can start, but then how quickly should we initiate therapy? So again, I saw this very interesting slide from 1994. Nothing new about it, but I would like to bring to your attention that if you were to start statin therapy for primary prevention in people at 35 years of age, you will reduce their chances of getting a cardiovascular event by almost 50%. As against that, if you were to start the same person on a statin after 55, the chances of reduction are only about 27%. So earlier the better, but once you start, how long should we treat? So this is a slide from the Prove It TIMI-2 trial about an acute coronary syndrome and high intensive statin therapy, which shows that even up to 2.5 years after the initial event, if you use high intensity statin, there is a significant increase in the benefits which we get against a normal dose of statin. So the deaths and CV events seem to be improving over a period of time, and thereby telling us that probably after acute coronary syndrome, when we start a high intensive statin, no point in coming down after 3 months, 6 months or so. Maybe 2 years, maybe 3 years, we don't know. But the longer we give the high intensive statin, better it is. Coming to the other drugs which I have been asked to speak upon, so this is where the statins act, preferably most importantly in the liver, but also, as I said, the cholesterol metabolism goes on in every cell in the body. Bempedoic acid again acts on the same axis, one step prior to the statin. So the synergistic effect of statin and bempedoic acid is not that high, but still we see in trials that when you add bempedoic acid to statins, you still do get a reduction in their LDL levels. As against this, we have our relatively benign but fairly effective molecule ezetimibe, which acts at the intestinal level and reduces the absorption of cholesterol. This is the trial, the Improve trial, which came way back in 2015 and which showed that if you add ezetimibe to a standard statin therapy, this was 40 milligram of simvastatin, to which 10 milligram ezetimibe was added, and over a period of 6 or longer years, you can see that in more than 18,000 patients which you have seen, the event rates are significantly less in patients who are on ezetimibe plus simvastatin. The events which were reduced were all types of events, cardiovascular events, strokes, revascularization, so on and so forth. And most importantly, and a very happy slide for ezetimibe, you see that if you give a monotherapy with a statin and if you add ezetimibe to it, there is no increase in side effects in all these things. So a very, very safe drug it is. And the safety is also proven in very elderly people, and this is a primary prevention trial from Japan. Oh, that's quite fast. Of people more than 75 years of age, there has been a reduction in LDL cholesterol, non-HDL cholesterol and triglyceride, and no significant worsening of HDL cholesterol, and the clinical events were also better with when you gave ezetimibe to this population. Coming to bempedoic acid, quickly I'll run through some of the things. The first trial which came was, of course, the Clear Harmony trial, where it just showed that with the use of bempedoic acid adding to statin therapy, you could get a significant decrease in LDL levels without any significant increase in the adverse events. But only last year we had this trial which showed the clinical outcomes, that is the Clear Outcomes trial, and which showed that not only did bempedoic acid reduce LDL and the HSCRP, but also all these events were better in these patients with, I'll take only a minute more, in patients who received bempedoic acid. Bempedoic acid very safe, very few side effects, only a very rare event of tendon rupture, which is extremely rare. Bempedoic acid has good reduction in patients with statin therapy or without statin therapy. In both of these subgroups, there is a good effect. We can now use a combination of drugs, and if you use a combination of ezetimibe and statin, it is non-inferior to a high-intensity monotherapy with lower side effects. And here it is, if you use 10 plus 10, atorvastatin, almost as effective in LDL lowering compared to 80 milligram atorvastatin. And if you start both of them together, you save a lot of time and you achieve your goals much faster. We can use bempedoic acid plus ezetimibe, just like you can use ezetimibe plus statin. You can use bempedoic acid plus ezetimibe, and now you can use it as a first-line therapy in high-risk patients, of course not in all patients, but high-risk patients. And you can use a triple combination of all three drugs, bempedoic acid, ezetimibe, and atorvastatin. And this is in primary prevention in hypercholesterolemia patients. And you see that if you use all of them together, then there's a reduction of LDL by almost 60%, and 90% of the patient achieved the things. This is the last slide. This is what I wanted to convey today. Though cholesterol is essential, LDL cholesterol is not essential. It can be safely kept very low. We should start therapy as early as possible, continue therapy for as long as possible, and you can use high-intensity statins for a long time. Serious side effects are very uncommon, and ezetimibe, bempedoic acid are very effective and very safe, and combinations, I think, are the future for all three drugs. Thank you.
Thank you, Dr. Bhavesh, for a very lucid and very informative talk.